A very good morning to all. Today we will be continuing the discussion on ARM. Today's topic will be clinical evaluation and management of anorectal malformation in a case of a neonate. Yesterday we had discussed regarding the embryology, etiopathogenesis and anatomy of anorectal malformations. So the contents of today's presentation will be a brief introduction regarding ARM, the basic classifications of ARM. Then we'll discuss regarding the associated anomalies which are present along with the ARM. Then how to clinically evaluate a case of male and female ARM and how to investigate the same case. And finally, we'll end up with the surgical management in a neonatal setup, especially how to do the colostomy properly, and in cases of low ARM, how to go ahead with the primary repair. Yeah. So coming to the introduction, anorectal malformation, they are present across a range of defects. Varying defects are present, and it can range from isolated malformations which has got a good functional prognosis to complex malformation with associated anomalies and a poor functional prognosis. The incidence ranges around 1 in 5,000 live births, and there is male preponderance to the incidence of ARM. And the anatomy, etiopathogenesis, and embryology were previously discussed, but we'll just have a brief revision of the sphincter anatomy before proceeding with different types of ARM. So we know that the sphincter muscle complex, or the three essential muscles associated with the sphincter control, can be simply defined with the help of this picture on the right side, which shows a funnel shaped structure, because a pelvic anatomy, especially that of the levator trainae, it forms a funnel shaped muscle structure. So if you see if you imagine this funnel, the horizontal lines shows the upper levator trainae fibers, and the vertical fibers are the muscle complex, which are vertically arranged striated muscles. And if you see laterally, there will be the lateral parasagittal fibers. So in a nutshell, we can simply define the muscle anatomy using this picture on the right side, and the same thing is shown in an anatomical manner on the left side. So in the first picture, it is in a relaxed state, so you can see the rectum going downwards and the levator trainae fibers. So what happens is that the upper levator trainae fibers, when it contracts, it pushes, or it brings the rectum anteriorly, and when the vertical fibers contract, it will pull the anus up in an upward manner, which is shown in the second figure. And when the parasagittal fibers contract, the anus will close. So this is very important for maintaining the continence. And again, just I'm revising the previously discussed topic. Mainly, the continence is maintained by the proper anatomy of the muscles, and by the normal anal sensation, and also the proprioception in the rectum when it is getting distended by the stools. And the third most important feature which helps in maintaining continence is the bowel motility, or the peristalsis. So all these three components are important in maintaining continence. So mainly in case of ARM, the absence of anal sensation is one important factor when we are considering continence, because the initial anal sensation when stool comes to the anal canal, and when it is sensitized by the stool, it helps in maintaining the continence. All these are maintained by pudendal nerves, and also by the spinal cord at S2, S3 and S4 levels. And autonomic innervation also comes from the autonomic ganglia from the same levels. Now coming to a brief discussion regarding the classification. So various classifications are stated. The first one to come was the international classification, which is based on the anatomy, and it differentiated into high, intermediate and low ARM. And then Wingspread simplified the same international classification, and then came the second classification. After that, Pena described a much more better classification, or a simpler classification, which combined both anatomy and the surgical management associated with that particular anatomy, because the international classification was mainly based on the anatomy. And later on, the latest classification, which is done by Krickenberg, which is shown here, and it was mainly based on the frequency of the different subtypes which is present, and he differentiated it into major clinical groups and also the rare or regional varieties, especially pouch colon, rectal atresia, etc. Yes, sir.
Are you aware of the other ones called Wingspread classification?
Sir, I had mentioned, sir, Wingspread modified the international classification into a simpler classification.
Okay, it's Wingspread is the place where the convention took place.
Yes, sir.
Okay.
Oh,
So
okay.
came in 1971.
Yes, sir.
Wing spread around 1982,
Yes,
and
sir.
that was followed by long. In fact, many of us still participate in it because that is basically based on the relationship of the rectum, rectal pouch,
Yes, sir.
to the sphincter complex. Basically, the levator drainage was thought was better.
Yes,
Then
sir.
Pena up with his own classifications, and Krickenberg is again a consensus group. Okay,
Yes,
go
sir.
ahead.
Yes. So, this is
How about all?
yes, sir.
You go ahead.
Yes, sir. So, this is simpler classification, which is based on the Pinier's classification. Along with that, he explained which all cases required colostomy and which all cases didn't require colostomy, where we can go for a primary pull-through. I'll come into the details of each entity later on. Now, coming to the associated malformation in the case of anorectal malformation. So, most of the babies, around approximately 50 to 60% of the cases of anorectal malformations have got one or more abnormalities that affect other systems. So, proper evaluation of a ARM case in the first 24 hours is essential. It determines the prognosis of the child. So, we'll start off with the involvement of the cardiovascular system. So, cardiovascular system is involved in almost one third of the cases. But in that one third of the cases, only 10% will require a intervention or a treatment. And the most common defect associated with ARM is usually an atrial septal defect or a patent ductus arteriosus, which is followed by tetralogy of Fallot and VSD. Other entities like transposition of great vessels are also seen. The second system will be gastrointestinal system. Along with the ARM, it is very important that we rule out other anomalies like especially tracheoesophageal fistula or a duodenal obstruction. So here comes the importance of an inventogram, which we do in a case of initial evaluation of ARM. Because if we are just concentrating on evaluation of only that ARM part, and if we are not doing an inventogram initially, we'll sometimes miss a duodenal atresia or a duodenal obstruction. So an inventogram is very essential in the initial evaluation of a neonate. And also it is very important that you confirm the patency of the trachea, the patency of the esophagus by passing an NG tube, because in almost 10% of the cases there can be association with a tracheoesophageal fistula. And the third important variety is spinal and vertebral anomalies. So they are more commonly seen along with complex ARMs or high ARMs. And the most common spinal anomaly is that of tethered cord. Here, if you see this ultrasound, you can see that the spinal cord is going till the L4 level. Usually it will end at around the L1 level. But in this case, it is going down and there is tethering as shown in the ultrasound. So USG is very essential in the initial period to rule out a tethered cord because it determines the functional prognosis of the child. And in the first 3 months, you can always go ahead with a ultrasound. Ultrasound is as good as an MRI in the first 3 months period. So after 3 months, if the ultrasound is inconclusive, if it is doubtful, you can do an MRI. But it will be very difficult to sedate the child and do an MRI in the initial days. And before 3 months, ossification doesn't set in. So ultrasound is always a good modality to investigate. And coming to the vertebral anomalies, the most common vertebral anomaly is a hemivertebra. And scoliosis, butterfly vertebra, and hemisacrum are the other defects. It is also detected with the help of an X-ray and also usually detected with the help of an ultrasound in one third of the patients with ARM. So another important aspect is to measure the sacral ratio. So in this case, usually to assess the sacral vertebra or the lower vertebra, we will always do a AP and lateral film of the spine. So in that you can assess for the sacral ratio because it determines the continence. So this is how you assess the sacral ratio. If you take an AP film, the first line or the A line will go across the uppermost part or the iliac crest, and the B line will pass through the lowermost region of the sacroiliac joint as shown by the pointer, and the C line will be passing through the coccyx and the greater trochanter. So sacral ratio will be defined as BC length divided by the AB length. In case of an AP X-ray, it should be 0.74 or higher. And in case of a lateral X-ray, it will be 0.77. A lower sacral ratio shows a poor prognosis and continence will be less. Now coming to the genitourinary system. Genitourinary system involvement is also seen in 1/3 of the cases to half of the patients in with ARM, and the incidence will be more with high ARM cases or complex ARM cases. And the most common anomaly which is found is a vesicoureteric reflex, which is followed by a renal agenesis or a dysplasia. Other abnormalities like cryptorchidism and also hypospadias are also found to be associated with ARM. Coming to gynecological abnormalities, it is an important concern when you do the initial management of an ARM, because 1/3 of the population can be affected. Uterine malformations or Mullerian abnormalities can be found, and uterine malformations predominantly bicoordinate uterus and uterine diadelphi is seen, and vaginal abnormalities are also seen associated with ARM. A vaginal septum can be seen or a vaginal atresia can be seen. In case of vaginal septum and all, there can be accumulation of mucus and vaginal secretion, and it can lead on to hydrocolpos also. The most important thing, especially in a case of when you see a case of cloaca, is that you need to rule out hydrocolpos initially itself. One, it can be identified via abdominal examination, or else if you do a peritoneal ultrasound also, you can rule out hydrocolpos, because if you initially concentrate only on diverting the stool by doing a colostomy, if you miss the hydrocolpos, it can cause bladder neck obstruction and in turn lead to megaureter. And also hydrocolpos can get infected and it can turn into a pyocolpos. It can complicate as a fistula, and it leads to a poor prognosis. So initial intervention for hydrocolpos is necessary, and it is as important as doing a colostomy. I'll come to the details of how to drain the hydrocolpos in the upcoming slides. Now coming to the initial clinic, how to clinically evaluate once you get a case of ARM. So as any case, the history, it starts off with history. We need to take a proper meconium history of the patient, birth history and meconium history, and also antenatal history. Usually antenatally diagnosis will be difficult, but sometimes in ultrasound and all, the hypodense area of the anal canal will not be seen, but it will be very difficult to appreciate because the foot part also comes near the anal canal, so it will be very difficult for a sonologist to differentiate. And the postnatal history and the birth history, the meconium history is very important. Whether they notice a meconium at the perineum, or whether they notice a meconium in the passage in urine, or whether the mother or the doctor has noticed the meconium staining near the urethral orifice. And then coming to the clinical evaluation, initially how to approach the patient with an ARM. Meticulous perineal examination with proper lighting is important. Otherwise, you might miss the findings and you might end up doing unnecessary procedure for the child. So, whenever you are doing an examination, do it with a proper lighting. And especially in case of a female ARM, this is how you hold the labia, and this is how you should separate the labia of the child so that you can visualize all the openings. In this case, in this figure, you can see the vestibular fistula, the vaginal opening, and the urethral opening can be seen separately. So these are the various clinical manifestations which we can come across. So the first figure shows a bucket handle type of deformity. So this is more like a low ARM with a perineal fistula with a skin bridge here. So sometimes the meconium can go through the skin bridge towards the root of the scrotum, which is seen in the second figure, and it can be filled with mucus, and this is known as white pearls. You can see the whitish debris which is seen inside the median raphe. And similarly, the meconium can also pass through the skin groove. So that is called the black pearl or the black ribbon appearance. Then other thing is presence of meconium at the urethral orifice. You can see the meconium which is coming through the urethral orifice, which suggests a urethral fistula or a bladder neck fistula, which can be an intermediate or a high AR. And this is in this examination, only a single opening is seen where you should suspect a cloaca. And the last picture, it shows a flat perineum. It is very important that you assess the gluteal folds and the gluteal cleft. In case of a low ARM, it will be well found. But in case of high ARM, the gluteal muscles and the sphincter complex will be poorly formed. And this is how you see, this is how it will present. It will be a flat perineum. So it will be a flat perineum, and usually the scrotum will be bifid scrotum. It shows a poor prognosis. And also in case of an imperforate anus, the anal pigmentation is also very important, because that pigmented part represents the area of the sphincter complex. And after examining the perineum, it is very important that you go ahead with the examination of the spine, because most of the children can have sacral agenesis, hemivertebra and all. So proper clinical evaluation of the spine is important. Then you should see for other anomalies, associated anomalies. So examination of spine, abdomen, and esophageal patency and cardiovascular system for any murmurs clinically, it is very important. Esophageal patency can be examined with the help of a NG tube. Then in the first 24 hours itself, you need to evaluate for the associated anomalies with the investigations like UHG spine and abdomen and KUB to assess for renal anomalies, and definitely a 2D echo to assess for cardiac anomalies in a case of ARM. I explained regarding the need for an infantogram, because in case of uh, atresia of the duodenum and all, the presentation can be found out in an infantogram. The most important thing in ARM which we do is a cross-cervical prone lateral X-ray, which should be done within the first after 18 to 24 hours of birth. So this is how you do a proper CTPL X-ray. The child should be kept in supine position, and the X-ray plate has to be kept on the lateral aspect, and the X-ray beam has to come properly in a perpendicular aspect towards the X-ray plate and the child. Any angulation can alter the interpretation. And the most important thing is that the abdomen should not be completely compressed. The child's chest should be touching the table, and the bolster should be kept at the pelvis, so that the rectum will be the highest point, so that the air will come and accumulate there. And the knees should be semi-flexed. It is very important, because most of the time when people do, they will flex the knees completely. It should be semi-flexed and not completely flexed. And the hip should be semi-flexed, and the knee should be touching the table like this. Now, how to evaluate the CTPL film? Usually, when you keep the child under for the CTPL X-ray, you should wait for 3 minutes for the air to come up, and then only you should take the shoot. And the X-ray cross mark should be pointed at the greater trochanter of the child. Now, coming to the points and lines of CTPL. So basically, there are 3 points: P point, C point, and I point. The P point corresponds to the pubis. The pubis is pubis is usually seen as a boomerang shaped structure here, as shown in the figure, and the midpoint is usually taken as a P point, and the C point will be the lowermost ossified part of the sacral vertebra. The coccyx will not be seen ossified, so it is always the lowermost ossified part of the sacral vertebra. And the third point will be the eye point. The eye point will be the lowermost part of the comma shaped bony structure known as a ischium. So this is the comma shaped ischium, and this is the eye point. Now coming to the lines. So the first one will be PC line, which is the line which is drawn from the P point to the C point, and it corresponds always to the upper limit of the levator complex. So it is an anatomical landmark for the bladder neck. And second one will be the eye line. Eye line will be drawn parallel to PC line. Eye line will be drawn parallel to PC line through the eye point, which is the lowermost point of the comma shaped ischium bone. And then you have the M line of Kremen. The I line usually corresponds to the lower limit of the levator, and anatomically it corresponds to the perineal body in females, and also the bulbomembranous junction in males. And there is M line of Kremen. M line is actually drawn. It is a line which is passing through the upper 2/3 and lower 1/3 of ischium, which is parallel to the PC line, and it is perpendicular to the longitudinal axis of the ischial bone. It usually corresponds to the puborectalis sling. Another doubt which comes here is that how to draw the eye line when there is sacral agenesis. So in that case also, the eye line you can draw with how to draw the PC line when there is sacral agenesis. In that case, you will have the P point, but the C point will not be you will not be able to take the C point. In that case, you can start a line from the P point, and the line should be drawn through a point which is at a junction of upper 1/4 and lower 3/4 of the ischial bone. So with that, you can draw the PC line in a case of sacral agenesis. So whenever you are doing the CTPL, you should always mark the anal pit with a barium die instead of keeping a metal instrument, so that it will take the contour of the anal opening. The position, normal position of the anal opening. And based upon the CTPL, it is divided into low, intermediate, and high ARM. This is actually not based on the length from the the normal anal opening site and the I line or the PC line. It is always based on the bony landmarks. This should be kept in mind. So if you draw the PC line and I line, if the rectal shadow reaches beyond the I line, it can be considered as a low ARM. And if it is between the I line and the PC line, it will be considered as an intermediate ARM. And if the distal shadow is well beyond the PC line, it is usually considered as a high ARM. Now we'll just see the pitfalls of doing a CTPL, which can alter the management. So one is an improper technique. The technique I had mentioned earlier. So we have to do in the proper technique. Otherwise, it will alter the anatomy, alter the finding. So especially when the child is crying, the puberectalis can contract and the lowermost part of the gas shadow can go up. So it will give a false perception of high ARM. And the most important thing is that you need to give time for the gas to reach the distal part of the bowel. So it will, and there should be abdominal distension for a proper film to for us to take a proper film. So this happens usually in 18 hours to 24 hours time. So initially, if you do the CTPL before that time, again you will get a wrong result. So you need to wait for doing a CTPL. And excessive pressure of the abdomen also give a false perception of low ARM. The bolster should be kept only in the pelvis part, so that the pelvis will be elevated up and the rectum will be the highest point, not the fistula. And especially if there is a fistula, there can be air leak through the fistula and can again give a wrong impression. And air trapping inside the vagina also can give a wrong impression of the distal air shadow. And other things which you should keep in mind is associated esophageal and a duodenal atresia, which can be found out in an infantogram, which we take along with the CTPL. Now coming to the evaluation of a male ARM case, how to go ahead.
And
Yes, sir. Yes, sir.
your presentation so far is crystal clear.
Yes, sir.
Fantastic. I really appreciate you
Yes, sir.
because you're conveying the concept well.
Yes,
your
sir.
choice words are very good. Congratulations.
Yes, thank you.
Only few things I wanted to ask you when most of the stock questions about lateral sheet through have been told by you.
Yes, sir.
But any idea about how this invertogram was described by whom, when, and what? How did they come across this PC line and I line? This was class.
Sir, CTPL was described by Narasimha Rao, sir.
I understand that is PCTL, but invertogram, this PPC line.
Yes, sir.
Sir, dissection, it was.
Who did it?
By Stephen.
Stephen, yes, sir.
Yeah. By Stephen. Stephen dissected some 25 fetuses. I think so. I don't remember.
The original
Stephen Wangstein Rice has.
Original invertogram was described by Wangenstein and Rice.
Yeah.
It is in 1905.
Yes, sir.
Where they took only an invertogram and looked at only the measurement. Okay.
Yes, sir.
Whereas like somebody is saying it is Douglas Stephen who did a lot of dissection. What it is on all dead babies with anorectal malformation, they took the pelvis and dissected the pelvis and placed wires, the metallic wires along the elevator edges, and then took X-rays.
Yes, sir.
By doing them, then they could identify that PC line and P line and everything corresponded to these things. Okay.
Yes, sir.
One.
Understood.
Number two, Kalen Rao is the one who described it, published it, but actually it was the original idea of one Dr. Chatterjee in Jipmer, Pondicherry.
Yes.
In fact, in St. John's and Ramaya, and I think he was in Mysore, and I think he recently passed away last year. It doesn't matter. Okay. Thanks.
And basically, why we prefer
Ramesh.
CTPL over invertogram is that.
Ramesh?
Sorry, sir.
Again, Pini has now come back to saying about the distance, 0.5 centimeter and 1 centimeter,
Yes,
and
sir.
it doesn't about PPC line. Somehow he generally has an antipathy towards Douglas Stephen,
Yes, sir.
and vice versa. Everybody else has an antipathy towards him. But since he is the one who sort of authority, it gets away with it. All
Yes,
right, go ahead.
yes.
The Srimurthy sir wanted to tell something.
Ramesh,
Yes, sir.
the original invertogram was done in Canada
Okay, sir.
by Professor Hugh Owen Wangenstein.
Okay, sir.
He was the first one to do the invertogram.
Sir.
Yes, sir.
Our Professor Adikeshulu, who was the professor of surgery at Bangalore Medical College,
Yes, sir.
was his first resident,
Okay, sir.
who also participated in the so-called invertogram situation.
Okay, sir.
Subsequently, Stevens came with the PC line, a little more clarity in the picture.
Yes, sir.
There was disadvantages of the invertogram, exposure in those days to high dose of X-rays to the mother or the nurse holding it and all that. As you rightly said, Narsim Rao, more than Narsim Rao, the man from Pondicherry, Mr. Chatterjee, was involved in the cross-table lateral description. That's for clarification. Okay.
Yes, yes, thanks.
And again, as I told, previously it used to be PPC line because of the Douglas Stephen school of thought. And again, Pine is now changing it to sort of the distance back.
Yes, sir.
The only problem when you're talking about distance is the magnification factor has to be kept in mind.
Yes, sir.
Because it depends on where you place the X-ray sheet and the X-ray cassette.
Yes,
If
sir.
it is placed closer to the child, magnification is not much. Whereas the other one, if you place it farther, there's definitely a magnification factor and you can't really go by the centimeter and the distance.
Yes,
All right.
yes, sir.
In fact, the other what we used to do earlier, in fact, was given up just for historical reason, is we used to do a perineal ultrasound to
Yes,
find the level of the pouch
yes,
and look at the distance. Okay.
yes, sir.
And it fell out of favor, but it's actually a good method, especially if you think it's bulging, you don't know whether you have to take a call between colostomy and no colostomy. Transperineal high frequency ultrasound is also good technique.
Yes, sir.
I think what people used to do, in fact, I had done during my MCH days, was to do a dye study. That is, look at the perineum, get an ultrasound, look at it, and put a dye and inside and see.
Yes, sir.
Okay, but those things are all outdated. But you need to know that these things were attempted. Second thing is there is absolutely no role for putting a coin there.
Yes, sir.
Why?
Because the pit will not be properly demarcated with the help, because coin is a flat entity.
Correct.
So we need to put barium paste at the anal pit.
Barium paste. Other thing what people used to do is to put a blunt pin or something longitudinally, or
Yes, sir.
in room. Then you can put that number 1. No? Previously, they used to have these numbers to put in the site. That is one. Okay. But anyway, barium paste. Go ahead.
Yes. Now, coming to the evaluation of a male ARM case. So, if you get a newborn male infant with an absent anal opening, so you need to first clinically evaluate the child within the first 24 hours for the associated anomalies. And as I said, how to investigate the perineum. In the same manner, we need to clinically evaluate the perineum of the child. So, once you inspect the perineum, and you need to wait for 24 hours. If you don't see a fistulous opening, you need to check whether meconium is present in urine or not. So you can do a urine analysis, or you can keep a wet gauze at the urethral opening and see for meconium staining. And you need to convey the same to the NICU staff also, because otherwise they might remove the gauze and they will not notice the meconium in the urine. So that is one thing we need to keep in mind. And second thing, if the meconium is present in perineum, or if there is a fistula, and in that case also you can do a cross-table lateral film, and if it is showing that the rectum is within 1 centimeter of the uh, normal anal opening site, you can go ahead with a neonatal primary post-surgical anorectoplasty. And if the meconium is present in urine, and if you do the CTPLA, if there is abdominal distension, then if the rectum is shown further than 1 centimeter above, that is high up, in that case, it is always safe that you go ahead with a colostomy. And I will come into the details of the colostomy in the later slides. And this is just a like how to go guideline regarding how to go through with a neonatal case of ARM. And you will do a stoma. And after doing the stoma, in that case, you can go ahead with a distal cologram at around 8 to 10 weeks of time. And this is not just a simple distal cologram, it is a augmented distal cologram, because you need to give a proper hydrostatic pressure when you are instilling the dye. Otherwise, the distal part will not get distended, because the striated muscles will keep the rectum collapsed. So you need to open it up, so to understand the lowermost point of the rectum. So it determines your management part. So if the rectum is, if the surgeon thinks that the rectum is reachable through posterior sagittal incision, later on you can go ahead with a PSARP. And if the surgeon feels that it is not reachable with a PSARP or a perineal incision, you will have to go ahead with a laparoscopic assisted PSARP. And later on you can, after 2 weeks after PSARP, you can start with anal dilatations also. And follow-up should be at 6 months, 1 year, and then later on annually. And continence assessment will be done at around 3 to 5 years of age.
Sethu?
Yes, sir.
One thing I want to just let you know is LARP is not anorectoplasty. It is laparoscope assisted anorectal pull through.
Pull through. Yes,
What is
yes.
the difference? Pull through.
Pull through and plus. Sir, you will mobilize the colon and then bring it down. In case of laparoscopic, pull through.
Plasty is?
Plasty, in the case, we'll have to dissect around the rectum and then free it from the urethral part, and then bring the rectum into the muscle complex side, sir, from the anterior aspect to the posterior aspect.
Describing the same thing in different words. Okay, let me clarify.
Yes.
When I say a pull through, what we do in laparoscopy is we dissect the rectum, separate it from the urinary tract,
Yes, sir.
identify the muscle complex and pull it through. Okay.
Yes, sir.
So it is. Whereas what Pinier describes, or at least that's what he says, is you reconstruct the relevator. Okay. You
Yes, sir.
reconstruct. So that he says is anorectoplasty.
Plasty.
That's why it's suggested anorectoplasty.
Yes, sir.
When you talk abdominal PSRP, then again it's a plasty.
Yes, sir.
Abdominal PSRP. Whereas in laparoscopy or the previously all the described procedures was a pull through.
Pull through.
Okay. Pull through, not a plasty.
Yes, sir. Yes, understood.
Go ahead.
Now coming to the same management of female anorectal malformation. So in that case also you need to determine clinically how many perineal orifices. It depends on how many perineal orifices are there. Whether it is a single opening, 2 openings are there, or 3 openings are there. Normally there will be 3 openings. One will be urethral opening in the uppermost part. The meeting will end in 5 minutes, sir. In that case I will restart the meeting. If normally there will be 3 openings. One will be the urethra, the second will be the vaginal, and the third will be the anal opening. So the first one, in case of a cloaca or a single opening, if only single opening is present, so in that case you should suspect a cloaca, and you need to evaluate for renal anomalies, and also a pelvic ultrasound on day 1 is essential, and along with that you do the other rectal screening. In cloaca cases, you need to definitely look for a hydrocolpos. Hydrocolpos means the vaginal outflow will be blocked and it will be filled up with mucus and sometimes meconium. And this can compress the bladder neck, and in turn it can cause hydronephrosis and also megaureter. So if there is hydrocolpos, then it requires a vaginostomy or a vaginal drainage along with colostomy. If there is no hydrocolpos, then definitely you can go ahead with a colostomy and then plan for the definitive repair later, depending upon cystogenitoscopy and cloacogram. If there are 2 openings, it depends whether there is a fistula or whether there is no fistula. And in case of a vestibular fistula with absent vagina, whether you will find only 2 openings in that case also, and in case of a rectovaginal fistula, you will go ahead with a colostomy. If only ARM without fistula is there, in that case you will primary management based upon the CTPL X-ray, and if the rectum is reachable, you can still go ahead with a primary PSRP. But if rectum is not safely reachable, it is always safe that you go ahead with a colostomy. It always depends upon the surgeon's skill and the baby's clinical condition, whether you are going for a colostomy or a primary PSRP in the neonatal period. After all, what we care about is that you should do a meticulous dissection, because it determines, in case of a low ARM, the functional prognosis is very good. So in that case also, if you don't do a meticulous dissection, then it can worsen the functional prognosis of the child. So if you are not confident about doing a primary PSRP, you can always go ahead with a colostomy in the first stage, and later on you can go ahead with a primary PSRP. And if there are 3 openings, especially in case of a perineal fistula or a vestibular fistula, if the surgeon is confident enough that he can do a proper repair, then definitely primary PSARP can be done in the neonatal period. And if surgeon wants to buy time in the initial period, you can always do a dilatation of the fistula, and later on, before 3 months itself, we can do a primary PSRP. Now we'll come to details of each case, each fistula case. We'll discuss management and also the various associated anomalies along with each. So first coming to male ARM, rectoperineal fistula. So this is the lowest type of anorectal malformation, and the patient, if it is stable and the surgeon has got experience, always this is a good case for a primary anoplasty or a limited PSRP. Usually we can go ahead with the primary anoplasty in this case, in case of a male ARM. And if at all you are planning for a delayed repair, then the fistula can be dilated with Hagas dilator, and the surgical repair is done within the first few months of life itself, because it helps in maintaining the anal sensation, because the anal skin is very sensitive and it has to get accustomed to the fecal matter, so that it helps in forming the continence later on. So usually such patients have an excellent prognosis for a bowel control, provided the patient receives a good operation and the sacral index is normal and the spine of the child is normal. In that case, if all these criteria are satisfied, such children, if a meticulous surgery is done, they will have an excellent bowel control. Important things, yes, sir.
Sethu, before you go further, I want you to let very clearly see when
Yes.
it says rectoperineal fistula,
Yes, sir.
it just says that there's an opening in the perineum.
Perineum.
It doesn't qualify to decide whether to do anoplasty or a PSRP.
PSR, yes, sir.
You have to understand is to see the configuration of the anus. Okay.
Yes,
For
sir.
example, if there's an opening and if you can pass a forceps or a mosquito and you can see a ledge. When I say a ledge, it means it's a thin septum which is covering the rectum. Okay,
Yes,
the
sir.
anal. Those cases are suitable for anoplasty.
Anoplasty.
But if you see a mucosal fold all around,
Yes, sir.
and it anal ledge, don't do anoplasty, because if you do anoplasty, you may end up with incontinence.
Yes, sir.
Okay. But just yesterday I was showing to those people who watched up with me that actually what was in a male child, what was supposed to be antepost anus, we thought we'll do. As I was telling earlier,
Sir.
when you're seeing the low, the two things are very important. One, to know the configuration. As I told, if the, when I say let's basically pass a mosquito or a probe inside the rectum and sort of pull it back, if you can see a sort of double layered skin and mucosa as a clear cut ledge, that means like a small little wall, then you can go ahead with the anoplasty.
Yes.
However, if you see the mucosa all around and there's no proper ledge, you better do not do a anoplasty, because it may cause incontinence.
Yes,
that's one. Second thing is, in antepost anus and other things, I used to simply do anoplasty, but I have also come to know, like Pena says, he insisted that the urethra be cannulated, because
Yes,
I understand this antepost anus may be sort of adherent to the urethra, just like a conventional rectourethral fistula. It may not be a fistula, but it may adherent. So if you are not careful about the anterior dissection, you may end up getting the urethral injury. So these things have to be kept in mind when you're doing a male ARM.
Yes,
all right.
Yes.
One. Second thing is male ARMs, especially these sort of low ARMs, present with huge abdominal distension. Can you say why?
Sir, because the opening will be too narrow.
But higher ARMs?
Sir, fistula will be wider fistula.
So whenever there's a wider fistula, it may be decompressing. Low ARMs sometimes may be so distended,
yes, sir.
especially late. So sometimes the child may be so hemodynamically unstable that you can't really shift the weight for the child's things to be picked up and to come to the OT. Such cases, what I have done is I have done anoplasty in the ward itself. This is a place where you can either give local, or if you can learn how to give caudal analgesia, it is good. I have done caudal analgesia in the NICU. The child is so hugely distended that I have done an anoplasty in the NICU. You can always stimulate and do revision later, but at least the decompression of the meconium and the last bowel may be necessary on an urgent basis in some children. All right.
Yes.
Go ahead.
So, Ramesh.
Yes, sir.
Can you comment on the subject of cutback?
Yes,
the
sir.
old story.
Yes, sir. Okay. See, cutback anoplasty was done for two types of cases. One is the type that I'm talking about is a place where there is a ledge. When there's a clear cut ledge, you can see it, you can make a cut and you can make sure that the mucosa is brought to the skin and sutured, okay, to have an adequate size. This is the correct type of cutback anoplasty, what is the right thing to do. Previously, for example, Douglas Stephen and who was there with him? I forgot. His associate, I think, I forgot. Anyway, Australians, what they used to do was in a case of female ARM, even if it is an antepost anus or a vestibular anus, they used to do a cutback so that the constipation is relieved, wider opening is there, and leave. Sometimes that alone may be sufficient, but sometimes that is not sufficient because the in a rectum and the anus, the vagina may be still stuck. Such cases they won't do what is called as a Burrington's explasty. But I think that is all given up now. But the thing I wanted to tell you was an antepost anus in a female child. Okay, if you are clearly seen that it is the opening is outside the vestibule, but within the perineum, but anterior to the normal sphincter area, sometimes may not really be requiring an operation. I remember Dr. Srimurthy sir telling, and I've implemented in quite a few patients where with just dilatations, with the child growth of the child, I mean with the dilatations, at least the constipation is taken care of. If you wait for the child to grow for about a year and a half, the perineum actually grows and the vestibule and the anus actually distances far enough. You don't really require to do in all cases. That's what I wanted to tell. Sir, you add anything, sir?
Yes, that is clarified. Thank you, Ramesh.
Yes. So, in case of a male ARM, after the surgery, also the main thing which you need to keep in mind is that the child should never develop constipation because it can in turn lead on to a megarectum or a megasigmoid and it can worsen the repair. So, constipation has to be treated proactively in the post-operative period.
Again, here, Sethu, make
Yes,
sure
sir.
that the dilatation program is continued at least for 1 year because, as you said, in low ARM, continence is a given.
Yes,
You
sir.
cannot get incontinence. Only thing is problem is constipation and
And
anal. The two things you have to keep in mind is one, whenever the child presents with tight anus, it can be either because constipation can be because of two reasons. One, the parents may not be compliant for anal dilatation program,
yes, sir.
and second, after doing dilatation for about a year, many times it's because of the functional constipation because of their diet.
Yes, sir.
Because the parents are very, very protective of children, especially those who have underwent an operation or those who are preterm. They tend to think that they are preterm for life. So they tend to indulge in them. They tend to sort of be spoiling them, having a tendency to spoil them. That the constipation may be because of the food habits.
Yes, sir.
So what is especially till about 1 year, when they come to you, make sure that the dilatation is done, but thereafter tell them about the necessity for the food and the diet habits. All right.
Yes,
Never go ahead.
yes. And the next entity will be the rectobulbar and the rectoprostatic fistula. That is a most common type of fistula in case of a male. That will be the rectourethral fistula. And in this case, both of them will usually require a colostomy in the newborn period itself. Because if you try to, because in this case, as in a newborn, the precise location of a fistula can only be determined with a distal cologram. So if you try to go ahead with a direct PSARP in this case, you might end up injuring the urethra. So it is always better that you go ahead with a colostomy first, do an augmented distal cologram, identify the fistula, and then later on do a PSARP. So as I said, perineal exploration will be risky in such cases. And the rectobulbar fistula has got a better potential for a bowel control compared to a high prostatic fistula, provided that the spine is normal and the sacral index is also normal. Now coming to rectobladder fistula, that will be the highest type of ARM and comprises around 10% of the cases in male ARM. And the prognosis for bowel control is usually poor, and it has got associated defects which are more common than in case of low ARM, and particularly it will be urological associated defects. And the colostomy is required, and in the newborn or the neonatal period. Later on, we can do a PSARP. So this is a simple structure showing all the fistulas in male. So if you see the deltoid, the triceps and the elbow, the deltoid will be representing the area of the bladder neck fistula, and the triceps will be showing the area of rectourethral fistula or the rectoprostatic fistula, and the A or the elbow will be showing the area of rectobulbar fistula.
Thank you, Sethu. Next time I go to gym and watch people, now I realize what to look for.
Yes, sir.
Go ahead.
And another entity which we can see is an imperforate anus without a fistula. So in this case, the rectum will be a blind ending pouch, and almost always it will be at the level of the bulbar urethra. And rectum is rarely found in pelvis. And one thing which we need to keep in mind is that this type of presentation will be commonly seen associated with a Down syndrome case. And the functional prognosis is good, and it will be similar to that of a rectobulbar fistula. But in this case also, better option is always a colostomy, because in rarely there can be a rectobulbar fistula. In this there can be rectobulbar fistula, and it will be difficult to differentiate it unless and until you do an augmented distal cologram. So this can be done. Augmented distal cologram can only be done if you do a colostomy. So in that case also, it will be a safer option that you go ahead with a colostomy in the first place. Later on, after augmented distal cologram, you can go ahead with the definitive procedure. Now coming to female ARM, and first one will be a rectoperineal fistula. It will be the lowest type of ARM in case of female, and associated defects are rare. And anoplasty in neonatal period can be done, or initially you can do dilatation if the child's condition is not stable, and later on they can go ahead with a definitive surgery in 3 months' time. It has got an excellent functional prognosis as in the case of male low ARMs. Second thing, or the most common case of commonest type of female ARM will be a rectovestibular fistula. A primary repair can be done in this case in the newborn period itself or within the first 3 months of time. It is very important that you confirm the presence of vagina also in such cases, and you need to rule out a vaginal septum, because it can be seen associated in almost 5% of the cases of vestibular fistula. Now coming to cloaca. Cloaca, as a definition is concerned, the urethra, vagina, and the rectum will.
Can I interrupt for a minute, please?
Yes, sir.
Can you go back to your last slide?
Yes.
The method we adopted prior to imaging, sophisticated imaging, between rectovestibular fistula and anteposed anus in a female, which occasionally occurs,
Sir.
is to put two Hagar's dilators of small size, one in the vagina, which goes vertically, and a second similar Hagar's dilator was passed. If it went parallel, it indicates a rectovestibular fistula with a more or less a common wall.
Yes, sir.
If it was an anteposed anus, the Hagar's dilator would go transversely backwards.
Yes,
In
sir.
other words, there would be a right angle between the two.
Sir.
So otherwise, that's why I came back to the question of cutback. Cutback is not suitable or acceptable for rectovestibular fistula,
Yes.
which was being done, misused. Only for anteposed anus, temporarily you can do a cutback in order to evacuate the meconium in the nursery or elsewhere. So this is a simple test we were following.
Yes, sir.
Pass two straight rods, one into the vagina, one into the rectovestibular fistula, and see whether they are parallel or right angles.
Yes, sir.
So then you take a call on what you decide to do on that.
Sir.
Okay.
Yeah, understood. Yes.
Thank you.
Thanks.
To continue what Shrimurthy sir was saying, see, apart from this, what was used to be commonly discussed was how to differentiate between anovestibular and a rectovestibular fistula.
Yes.
Because those days, what we used to consider anovestibular fistula as a low variety, and this thing rectovestibular as an intermediate.
Intermediate. Yes.
So basically, the length of the fistula used to be determined either by means of a same thing, like what sir said. One more thing is to put in a Hagar's dilators, a thin one, to see where it preferentially goes upwards or caudally. Okay.
Sir.
Second option was in the Foley's catheter test. That is, we used to put the Foley's catheter and inflate it, pull it down, and then mark the level at the skin level, deflate the balloon, pull it out, and measure the distance between the balloon and the marking. Based on the distance they used to do. But practically, over the period of time, I think we stopped to differentiate between rectovestibular and anovestibular because of two reasons. One, even a rectovestibular fistula, once it is sort of distended, it sort of pushes it down and looks like a anovestibular fistula. One. Number two, practical management between the two has not changed because both of them is simple. If it is decompressing well, we'll go ahead with the primary PSRP. If it is not decompressing well, we try to do dilatation. If dilatation is working, it is fine. If the dilatation is not working, we go ahead with the colostomy. Full stop.
Yes.
At the time PSRP, if you find it difficulty, we do a covering colostomy then. The
Yes,
management simplified, so we stopped using the words as rectovestibular or anovestibular fistula. I simply call it vestibular fistula. That's it.
Yes, sir. Understood. Yes. So coming to cloaca, the urethra, vagina and the rectum will join together as a common channel and opens as a single orifice in the perineum at the location of the normal urethra. So this malformation is yes, sir.
Just to complete the other thing,
So,
sometimes in female children, especially this sort of fistulas, fistulas and ARMs may be missed because child is decompressing. Most of the neonatologists, like what Dr. Shrimurthy sir always says, looks at the things which need not be addressed. For example, they are looking at the murmurs, they are looking at CNS, and they are looking at other things, whereas they simply don't do orifice count. They don't look at the perineum, they don't look at the other things which can be corrected then and there. Very many times, these sort of antipostjanous and vestibular fistulas are missed at birth. They present as constipation when the child is weaning started around 3 to 4 months of age. So, anytime you have a child who comes at 3 to 4 months of age with constipation, look for anorectal malformations, low varieties. All right, you pick it up. Many.
yeah, yes.
Go ahead.
Cloaca, in case of cloaca also, it is very important that you evaluate for the hydropulpous or the hydroureter nephrosis part or the megaureter. And many of the times, if left unattended, it can go, progress on the pyopulpous and it can fistulate. So it requires drainage along with the colostomy. Drainage can be done in various modalities. One is if it is a huge swelling in the abdomen, you can always go ahead with a vaginostomy, and you can place a perineal catheter, or you can even do a transabdominal pigtail catheter, which can be USG guided. And most important thing is that the drainage has to be left in place until you do the primary repair. The functional prognosis depends on the length of the common channel and also on the urethral length. Usually the common channel length varies between 0.5 to 7 centimeters. A common channel which is longer than 3 centimeters usually suggests a more complex defect and having a less favorable prognosis. And it is the one that often requires complex maneuvers for urethral and also vaginal reconstruction. You should keep in mind that there can be duplication of the Mullerian structures, which can occur in almost half of the patients with cloaca compared to other ARM cases. And almost all the patients with cloaca have an associated urological defect which has to be evaluated and taken care of. So almost all cases of cloaca requires colostomy plus or minus vaginal drainage if there is hydropulpous. Now coming to the last entity in female ARM, that is imperforate anus without fistula. Just as in
Sethu?
Yes, sir.
Cloaca, there are two varieties. If you want to keep all the options open, it is better to do ileostomy
Yes,
because you
sir.
don't know the bowel which is required.
Sir.
Other thing is to do also think about is you can do an end sigmoid colostomy. Okay, because what happens when you're doing a cloacal repair, the priorities are clear. The common walls, the first priority, whatever the common wall is available, is given to urethra, then to vagina, then to rectum.
Yes, sir.
So if you look at it, the common channel, the last terminal for 3 to 4 centimeter or 5 centimeter is ultimately not going to be available for rectum. In such cases, you basically, after the dividing, you are going to do a pull through. So sometimes it may be worthwhile to consider a end sigmoid colostomy so that whatever is there below can be utilized for urethra and vaginal reconstruction,
Yes.
and the rectum can through. But if you want to keep all options open, it's better to do a colostomy or a right. Okay, go ahead.
Yes. And imperforate anus without fistula also, as in case of male ARM, it is associated with Down syndrome, and a primary repair or a colostomy are both appropriate options, but safer option will be always a colostomy. And other rare entities are also present, like rectal atresia and stenosis, and it accounts only for less than 1% of the anorectal malformation. In these cases, the difference is that there will be a normal anal canal, and the obstruction or the narrowing will be located at around 1 to 2 centimeters above the skin level. Usually they have an excellent prognosis for bowel control since the sphincter mechanism is well developed and the anal canal is present. And about 1/3 of the cases have an associated presacral mass, and it depends on the type of the rectal atresia. Sometimes there can be a membranous covering only. In that case, you can endoscopically resect it off and maintain the continuity. And other cases which separates the anum and rectal canal, if the gap is more than 2 centimeter and all, you can always go ahead or treat it as a normal ARM case or a high ARM case and go ahead with a colostomy and followed by a primary repair later on. These are rare compared to the other presentations of ARM. Before discussing that, other rare entities include pouch colon, which is more common in northern India, and in that case also usually the management depends upon the type of the pouch colon, and Rauser has classified it into 4 types, and depending upon the type also you can manage the pouch colon. Usually a colostomy or a ileostomy is done, and the fistula, which is a wide fistula between the distal pouch and the bladder, has to be ligated, and you can either do a resection of the pouch along with the primary surgery or later on as a stage procedure. Usually the prognosis in case of a pouch colon will be poor.
Sethu, how to identify pouch colon?
Sir, pouch colon in an X-ray, clinically in an X-ray, a large dilated air fluid level bowel part will be seen in the abdomen. If you do an X-ray, sir.
Right, but again, even in a case of regular anorectal malformation, it can have a distended rectum or distended sigmoid colon. How do you differentiate between pouch colon and that?
Sir, clinic on table there will be loss of frustrations and appendices epiploica will not be seen in case of a pouch colon.
No, X-ray.
X-ray.
Anybody else? If you take an AP picture, you will be seeing that the pouch that you talked about
It's fine.
more than half the abdomen. Okay.
Yes, sir.
Then it is a pouch colon. Okay. Once you have a pouch colon, the entire disease entity is very different. Usually it is to be seen only in North India, but I've seen quite a few patients in South India, perhaps because there is a migrant population. So North Indians may also come and sort of it can be seen. I've seen quite a few cases of pouch colon. Okay.
Yes, sir.
So on a plain X-ray, you will be able to you see that is one of the reasons for your invertogram that is suggested.
Yes, sir.
In invertogram, you can see the abdomen component also. Okay, where you can see a distended loop of bowel which is more than half the size.
Yes, sir.
And since you talked about X-ray, the necessity to do an X-ray to look for duodenal atresia, my question is if there's an associated duodenal atresia or jejunal or ileal atresia, how will you investigate? Because is invertogram feasible?
No, no, sir. It is not feasible.
It is possible that the child can have esophageal atresia and anorectal malformation. If that is the case, how do you approach the case? Anybody?
Sir, we'll have to do a simultaneous esophageal repair, TEF repair, and then do a colostomy at the first place.
What is the priority? Because the anesthetist, you know, our anesthetist, they say the child cannot be snap-free procedure.
Yes, sir.
So what?
And then fistula, tracheoesophageal fistula ligation will be the first surgery.
Absolutely. So fistula ligation is most important because that is the most life-threatening.
Yes, sir.
Then it's permit to do esophageal anastomosis if you can wait. Third option, then you do the duodenal atresia. And then what do you do for the rectum? You don't know whether it's high variety, low variety, intermediate.
Sir, you can always safely go ahead with a colostomy.
Absolutely. When in doubt, do a colostomy. Do a colostomy.
Yes.
That is going to, I think, take home message. When in doubt, colostomy.
Yes.
Okay? Because always say, it has
Yes.
so happened, whether it is intermediate, low variety, I've done a colostomy, and then when you go back to do the final procedure after the distal colonogram, you realize it's a low variety, which could have simply done. It is okay. It is okay. It is
Yes.
okay. You're not doing anything. All right.
Yes.
One comment, Ramesh.
Yes, sir.
We have had situations where you have rectal atresia, duodenal atresia, and esophageal atresia.
Yes, sir.
At that situation, the simplest is to do a gastrostomy.
Okay.
At that point of time, you are protecting the lung from reflux
Okay.
and the over distension of the stomach. So you can buy time to resuscitate the child. Gastrostomy can be done under local or modified anesthesia. And
Yes.
then, as you said, esophageal atresia requires priority, followed by duodenal atresia and rectal atresia in that order.
Yes, sir. Go ahead.
Yes. Now coming to the surgical aspects which we do in a immediate neonatology setup, especially we need to know about the colostomy. It is different from a normal loop colostomy which we do. So the colostomy in case of an ARM has to be done meticulously. So first of all, we need to understand is that it is a divided stoma with a proper skin bridge, and where should we exactly bring out the proximal stoma is also important, because this is actually divided stoma. If you see the picture on the right side, the proximal stoma is made out exactly at the end of the descending colon, where it comes out from the retroperitoneal part. So that the rest of the colon will be fixed towards the posterior abdominal wall, and the risk of prolapse will be also very less. That is the area where you will bring out the proximal stoma, and then there should be a normal skin bridge followed by the distal stoma. Distal stoma or the distal opening is narrowed so that only a small opening is present to give a distal washes and also for the mucus to come out. It is basically a mucus fistula. Another important thing which we need to consider when you are doing the colostomy is that it should be a divided stoma, because you don't want the stool to get spilled from the proximal
Sethu,
stoma. Yes, sir.
why don't you discuss what we do? This is given in the textbook, agreed.
Yes, sir.
But what we do is not this, and we are generally don't face any other problem even if we do what we are doing, in the sense the loop colostomy.
You look colostomy. Yes, sir.
Correct,
Yes,
no?
yes, sir.
This is more of theoretical aspect that you're talking, but what we do also are covering all these points.
Yes, sir.
Anyway, go ahead and explain about loop colostomy that we do also.
Yes, sir.
Yeah, and how to prevent so-called spillage in the loop colostomy, and what are the advantages of loop colostomy or divided colostomy in the newborn period?
Yes, sir. Divided colostomy will be technically challenging when compared to a loop colostomy, and the proximal stoma has to be wide and the distal loop should be kept narrow, so that spillage will be limited in case of a loop colostomy. Another thing which we need to keep in mind is that the distal part of the bowel in case of a the stoma, distal part of the bowel has to be kept to a sufficient length, so that later on if you are doing the PSARP or a pull through, you will have sufficient amount or sufficient length of sigmoid and distal bowel for a proper repair. And another thing is the distance between the proximal and the distal loops in case of a divided stoma. You should keep a proper skin bridge between the two, so that you can apply a colostomy bag at the proximal loop, and it will not hinder the opening of the distal loop.
Is
So,
this the practice at the institute now, that
No,
you
sir.
do
Deepak was trying to-
divided
No, sir.
colostomy?
No, sir. No, sir. That's what Deepak was trying to tell. This is what is described, insisted by Pinia.
Pinia.
In fact, last to Bombay for a work, I think 4 or 5 years back,
Yeah.
that he got the distal colostomy revised 3 times to suit his need. I
Yeah.
don't think he's so much worried about it, because the loop stoma functions in all our practice for the last 25, 30 years that I've seen. It's
Yes.
very well, and we have not, and that is approved by all, sir. Everybody in the department is doing only sigmoid loop colostomy.
yes.
Okay, thanks.
Another disadvantage of a divided loop colostomy is basically there is a possibility that you can disrupt the marginal vessel because you are taking it too far away. Okay, so theoretically speaking, the rectal blood supply and the distal loop supply may be hampered because of that. Whereas a sigmoid loop colostomy, you are retaining the marginal vessel. All right.
Yes. And the stoma should be kept in the left lower quadrant in the flat area, so that the stool can be directed outwards properly. And usually we will prefer a colostomy in the descending colon, sigmoid colon junction. And transverse colostomy is not preferred, because if you are doing it high up, it will be very difficult for us to give the distal washes and to keep the distal patency, and also to wash out all the mucus plugs and the feculomas. And there can be longer length of colon can go into the disuse. Microcolon can also form because of disuse, and longer length will be lost. So in that case, a transverse colostomy is not an option. Always a distal descending colon loop colostomy has to be done. And whenever you are doing the colostomy, at that time itself, you need to give a proper distal wash so that it will be cleared of all the feculomas and the meconium, because in turn it can lead on to if there is a communicating fistula between the distal pouch and the bladder or the urethra, it can in turn lead to urinary infection. So this has to be prevented with a proper wash on table at the time of surgery, and also in the postoperative period through the distal opening.
Also for absorption of urine through the colon.
Yes, sir.
Yeah. So if you have a long length of colon, right transverse colostomy, so if there is a wide fistula, urine may go into the colon and
Yes,
may get absorbed and may lead to problems.
Yes, sir.
Okay, so you right this. Similarly, a colostomy is a high loop sigmoid colostomy or high sigmoid loop colostomy. It is not a junction between transverse colon and the sigmoid colon, because in that case, you squeeze it and bring it to the surface.
Sir.
You do not.
Yes.
So you do the highest possibility of, that is, the level of rectosigmoid, I mean, high loop sigmoid colostomy.
Yes, sir.
Okay, before you go further, I wanted all of you to be crystal clear about the methods of colostomy. I see varying techniques. I think I've taught you quite a few of you, but I feel the colostomy technique has to be perfected. If it is done well, it can be done quickly without any complications. Okay.
Yes.
So, for example, the things which I do, I will rather tell rather than ask questions. I don't know. I think I've told many of you. For some others, it may be necessity. Basically, make a transverse incision instead of make an oblique incision. Unlike in Hirschsprungs, in Hirschsprungs you make a oblique incision so that can be incorporated in the hockey stick incision.
Yes.
Whereas in a anorectal malformation, putting a small transverse incision, the cosmesis in long much better because you do not do anything at the time of colostomy closure. One. Number two, best is to identify spino-umbilical line, identify the junction between the upper 2/3 and the lower 1/3, put an incision lateral to that, not medial, so that the incision is quite lateral. At that level, you do not get small bowel, you get only sigmoid colon. The moment you make a muscle cutting incision, go inside, generally the first loop that you see will be the sigmoid colon. I don't know how many of you, can anyone of you tell me how to identify the sigmoid colon from small bowel? Because all sigmoid colon will be filled with arc. You will not see ostrations. Anybody?
The vascular pattern of sigmoid and small bowel, sir.
Very true. So in a small bowel, you see that the bowel loops, the vessels will come up to the small bowel edge, but will not climb over it. You will see only the small vessels. Whereas in sigmoid colon and transverse any colon, you will see the vessels actually climbing over the wall. So that is a clear-cut distinct identity for the colon. One. Number two, please, this is again I learned from Dr. Srimurthy sir. One more thing, whenever there is a distended sigmoid colon, you will realize that the what you see up is the lower and lower is up. Because what happens whenever there is a distended colon, the sigmoid colon tends to move towards the right iliac fossa. In that case, the upper sigmoid actually may be going upwards than lower down. Because another common mistake is people twisting. They put the lower part up and upper part lower down. The colostomy may not be functioning. So you have to identify that. One, the moment you identify sigmoid colon, if you can sort of gently deliver, it will be good. Okay, then identify which is proximal distal, and if necessary, you can put an 18-gauge needle at least to decompress the air. Once you do that, you will be able to get it. Put a small little feeding tube or something below and do a simple sigmoid colostomy. Doing a colostomy, there is absolutely no necessity for you to even touch a small bowel. If you do this technique, it will come out very easy. And second thing I realize is you do not need to put too much of sutures to fibros, because colostomy closure becomes difficult. All you require to put is 8 stitches. Make sure that the what do you call the bridge is higher up, or it is fully functionalized. Okay, make sure that the spur is taken up. This can be done either by lifting the feeding tube that is sort of put across, or you can even put a few sutures between the two limbs to make sure that the limb is kept up. And as you rightly said, most important, spend about 10 minutes in washing out the distal part, taking out as much of the meconium as possible. Spending this time is very important. Otherwise, there will be feculoma. There will be a problem during the definitive procedure. All right.
Yes.
I think I made.
Yes.
Go ahead.
Yeah, coming to the final slide of.
Sethu will skip this. Definitive procedure anyway will be discussed in the next.
Yes, sir. Definitive procedure and surgical details will be discussed in the upcoming class. So,
Yeah.
details of the surgery.
So only you need to know about two things about neonatal primary PSRP. In fact, there are large groups in Varanasi and Chennai who are actually propagating, and Chandigarh. They are propagating neonatal PSRP. Any idea about what is their rationale? Why are they saying primary PSRP in the newborn period? Male child also.
Sir, because they will not follow properly. So
No.
no.
You do. In fact,
They get accustomed to passing from below the rectum. That is one thing, this thing, sir. One more is planes are they're good enough in neonatal period.
Okay. Partly both of you are right, both the points, but I will continue. One is the planes are much easier to dissect in a newborn period. Whoever has done neonatal Hirschsprung or primary PSRP, you will understand that it is actually much easier in younger age group because the fibrosis will be much less. Dissection is easier. But unfortunately, what happens? You require a lot of gentle dissection, a lot of experience to do it because the surrounding structures are very high. So you have to make sure that you do not do that. So one, apart from planes being solved easier, second important thing is they feel that the brain imprinting is much better because you realize that what all you are doing in the long term, the continuous mechanism is dependent on a lot of things. One about anatomical reasons, the local perineal muscles which actually overtake the functions because all of them may not be fully developed, and the brain control and the spine control. They feel that if you do a primary PSRP very nice, the adaptation is much better and continuance is much better. I mean, this is theoretical aspect, but we don't know how much of it is practically borne out. For example, in fact, I was discussing with Kailan Rao once and asked him, sir, because that is the time when we were actually trying to do primary PSRPs and we had quite a few issues. So I was asking to him, and I was in a conference next to him. I said, sir, how are you doing? Sir, no, I do 20 minutes. I do faster than a colostomy. I said, that is okay, sir, but tell me what are the techniques? But what is happening is, more than Kailan Rao, there are people like, for example, A.N. Gangopadhyaya and the Chennai group who are fairly reliable and they do not make exaggerated claims like Kailan Rao. In fact, Kailan Rao, I remember, he comes out and says, after doing a primary PSRP, it is more content than a normal child. Sir, how is it possible? He says, no, this child has attained continence earlier than a normal sibling. It is difficult to believe. But what I'm saying is there are a lot of reliable people who are actually very trustworthy people like Gangopadhyaya and Chennai people, Senior Raj and all, they say the primary PSRPs are feasible. So, but I don't know because we tried it, but in a large volume center like ours where there are a lot of trainees, I'm not too comfortable trying to do primary PSRPs in male children. Okay. I think we discussed enough.
Yes, the surgical details will be covered in the upcoming classes, sir.
Fair enough.
Yes.
Right, illustrations, your slides, your presentation, your descriptions, your command on English, everything was very good. Congratulations.
Thank you.
Deepak, anything you want to say? Deepak?
All, sir.
Okay. Sorry, I forgot that you are the moderator. Then we become the host and you become the moderator.
Thank you, sir.
So thank you, sir.